Welcome to the 212th webinar of the Organismo Andino de Salud, Convenio Hipólito Unanue. It has been 3.5 years of continuous interlearning since we started this webinar cycle in May 2020. Today, Thursday, March the 14th, 2024, we are pleased to present this webinar entitled The Cost of Inaction in the face of tuberculosis. At the Andean Health Organization Hippolyte Agreement, we promote health and well-being. For us, it is a priority to contribute to ensure that public policies are effective in guaranteeing human rights, especially the rights of children and adolescents. In this context, it is important to highlight an important concept that contributes to well-being: positive peace, which not only implies the absence of violence, but also the presence of conditions that favor comprehensive human development. It is essential for the well-being and health of people, as it allows the rights to be respected, their needs to be met, and their capabilities to be enhanced. It also contributes to preventing and reducing risk factors that affect physical, mental, and social health, such as poverty, inequality, discrimination, stress, and trauma. Therefore, from the Andean Health Organization, we promote positive peace as a fundamental value to achieve comprehensive and sustainable health in our region. It is also essential to strengthen intersectoral and transdisciplinary work capabilities, regional integration, and international cooperation to make social and environmental justice a reality, as well as to understand that children and adolescents are not the future. And we have been repeating this, they are the present. We firmly believe that the One Health approach is indispensable to achieve the highest possible level of health in our populations. Let's remember that on what we do now, the development of our populations will take place. Reflections on these and other priorities relevant to health and well-being can be found in the monthly newsletter, and it is available on the website. Please leave us your name, organization, and country from which you are joining us through the comment box of Facebook chat or YouTube Live. In this same space, you can leave your questions or send them via email, webinarorasconu@gmail.com. To access the certificate of attendance to this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook or YouTube live chats. Please remember to check that your email is spelled correctly. This webinar will begin with an institutional greeting, followed by presentations by our speakers or videos, and a question and answer session. To begin this important day, I give the floor to Dr. Maria del Carmen Calle Davila, Executive Secretary of Horace Konu. Go ahead, Dr. Calle.
No le escuchamos, doctora.
We can't hear you, Dr. Calle.
Buenos días, buenas
Good
noches,
morning,
buenas
good
tardes, según
evening,
donde
good
estén.
afternoon, depending on your
Cada
location.
año sabemos que se
Each year,
conmemora
we know
el Día
that
Mundial de la
we
Tuberculosis
commemorate
para
the World TB
sensibilizar a
Day
la opinión
to
pública
raise
sobre las
awareness
consecuencias
in the public
devastadoras
opinion of the
sanitarias,
devastating health,
sociales y
social, and
económicas de la
economic
TB, y
consequences
para
of
redoblar los
TB, and
esfuerzos
to
para
redouble
acabar con la
efforts
epidemia
to
mundial
end the
de
global
tuberculosis.
TB epidemic.
La tuberculosis sigue
Tuberculosis
siendo una
remains
de las
one of the
enfermedades infecciosas más
world's
letales del mundo
most lethal
y es una
infectious
expresión
diseases,
clara de la desigualdad.
a clear expression of
Recordemos
inequality.
que entre el 2014 y
Let's remember
2015,
that
todos
between
los
2014
Estados
and
miembros de la
2015,
OMS y las
all
Naciones
the WHO
Unidas
member
se
states and
comprometieron
United
a poner
Nations member
fin
states
a la
committed to
epidemia
ending
mundial de la
the
tuberculosis
global TB
mediante
epidemic
la adopción de
through the
estrategias
adoption
fin a
of
la
the WHO
tuberculosis de la
and
OMS y
TB
los ODS
strategy and the UN SDGs.
compromisos
These
se
commitments were
reafirmaron
reaffirmed
en dos
at two
reuniones de alto nivel de las
UN
Naciones
high-level
Unidas
meetings
sobre la
on TB
tuberculosis en el
in
2018 y más
2018
recientemente
and
en septiembre
most
del
recently in
2023.
September 2023.
Del reporte global de la
From the
TB
Global
2023,
TB Report
OMS informó que hasta
2023, who
2019
reported
se habían
that
logrado avances en la reducción
progress
de
had
los
been made by
casos de la
2019
enfermedad de
in reducing
tuberculosis,
the burden
pero
of
la pandemia de
TB, but
COVID-19
the
fue un
COVID-19
revés
pandemic
importante
was
que
a
revirtió
major
los
setback
avances
that
anteriores.
reversed earlier
El
gains.
número de
The
personas
number
que
of people
accedieron a la atención de
accessing
la tuberculosis
TB care
disminuyó
declined
sustancialmente
substantially
en
in
2020
2020
y se
and
recuperó
recovered only
solo
partially
parcialmente en
in
2021,
2021,
lo que provocó un
leading
aumento
to an
tanto del
increase
número de
in both
personas
the
que
number
mueren a
of
causa de la
people dying
tuberculosis
from TB
como del número de
and the
personas
number
que
of
enfrentan la
people
enfermedad.
coping with the
En
disease. In
2022
2022,
se produjo
there was an
una recuperación
encouraging
alimentadora
recovery
en el número de
in the
personas
number of people diagnosed
diagnosticadas
and
y
treated
tratadas
with
con tuberculosis.
tuberculosis.
Sin embargo,
However,
el mundo en su
the world as
conjunto
a whole
y la
and
mayoría de las
most
regiones y
regions and
países
countries
como los
like
nuestros
ours
están lejos de
are far
alcanzar los
from
hitos
reaching the
y
milestones
objetivos de la
and
estrategia
targets
fin a la
of the
tuberculosis.
NTB
A
strategy.
pesar de ser prevenible y
Despite being
generalmente curable,
preventable and
la
generally curable,
tuberculosis fue la
TB
segunda
was
causa
the
de
second
muerte en el mundo
leading cause of
en
death
2022,
in the world in
después de
2022
la COVID-19,
after
y causó
COVID-19
casi
and
el
caused
doble de
almost
muertes que el
twice as many
VIH-Sida.
deaths as
Cifras
HIV/AIDS.
preocupantes como
Worrying
en el
figures
mundo se han
such
salvado
as, quote, in the
aproximadamente
world, approximately
74
74
millones de vidas
million
desde el año
lives
2000.
have been
Sin
saved
embargo,
since the
en el
year 2000.
2022
However, in
contrajeron la tuberculosis
2022,
10.6 millones de
10.6 million
personas.
people
Y si hablamos de las Américas,
contracted
cada
tuberculosis. And
día
if we talk about the
cerca de
Americas, every day
850
about
personas enferman de TB y cerca de
850
90
people fall ill
personas
with TB
pierden la
and
vida.
about 90 people
Otras
lose
cifras
their lives.
preocupantes del
Other worrying
2022
figures
son que el
from 2022 are that
55% de las personas
55%
que
of people
contrajeron la
who
tuberculosis fueron
contracted TB
hombres,
were men,
el
33%
33% mujeres y el
were women, and
12%
12%
niños
were
de
children
0 a 14
aged
años.
0 to
A nivel
14
mundial,
years.
se estima
Globally,
que
an
410.000
estimated
personas contrajeron
410,000 people
tuberculosis
contracted
multiresistente o
multi-drug resistant
resistente a la
or
rifampicina en el
rifampicin
2022.
resistant TB
En
in
resumen, no se
2022.
alcanzaron
In
las
short,
metas
the
mundiales
global
que se
targets
fijaron en la
that
primera
were
reunión de
set
alto
at
nivel
the
de las
first
Naciones Unidas
United Nations
sobre la
high level
tuberculosis
meeting on
del
TB
sexenio del
for the
2018 al
5-year
2022.
period
La
from
meta
2018 to
original
2022
era
were
que
not met.
debíamos dar
The
tratamiento
5-year target
contra la
said that we should
tuberculosis
give
a
TB
40
treatment to
millones de
40
personas,
million people.
pues dimos a
We
34.
gave treatment
Que
to
30
34
millones de
million,
personas
that
debían iniciar
30 million
tratamiento
people should start
pediátrico contra
preventive
la
TB
tuberculosis, pues
treatment.
iniciaron 15.5 millones de
15.5
personas,
million
que al
people
menos
started,
13 mil
that at least
millones de dólares debían estar
$30
disponibles
billion
para
should
el
be
2022
available by
y solo se
2022.
contaron con
Only
5.800 millones de dólares.
$5.8
Alrededor
billion
del
were
50% de los
available.
pacientes
About
con
50%
tuberculosis
of
y
TB
sus
patients
hogares
and their
afrontaron
households
costos totales,
faced
gastos
total
médicos
costs,
directos, gastos de
direct medical
alimentos y
costs,
costos
non-medical
indirectos,
costs, and
tales como
indirect
pérdidas de
costs,
ingresos,
such
que son
as lost
considerados
income, that are
catastróficos.
considered
Más del 20% de los
catastrophic,
ingresos
more
anuales
than
del hogar,
20% of
un
annual
porcentaje
household
muy
income,
superior a la
well
meta de
above
la estrategia
the
fin a la
WHO
tuberculosis
and
de la
TB
OMS,
strategy target
situado en
of
0%.
0%.
Este dato pone de
This
manifiesto
shows
que
that there are significant economic and financial barriers to accessing and completing TB treatment, barriers that must be removed by accelerating progress toward universal health coverage and improving levels of social protection. That is why we named this webinar, The Cost of Inaction in the Face of Tuberculosis, because inaction is a much broader concept than just the absence of action, since it refers to the non-fulfillment of an obligation or lack of commitment to others. All inaction has consequences. To end the global TB epidemic, the commitments made at the 2023 UN High-Level Meeting on TB need to be translated into action. If we want to move towards TB elimination, coordinated and synergistic work is required among the different actors involved in the response to TB, both from the public and private sectors, with civil society being one of the key actors. Here, the social observatories implemented spaces that serve as platforms for social surveillance, political advocacy, social monitoring, and contribution to national responses against TB become important. We hope that in this webinar we can have details of the results of this high-level meeting, as well as the challenges and obstacles from PAHO and WHO through Dr. Ernesto Montoro, WHO PAHO Laboratory Integration Advisor. Next, Dr. Lucica Dichiu, Executive Director of the Stop TB Partnership, who has kindly sent her video, as well as Dr. Meredith Brooks from Boston University, who will allow us to appreciate what they mean by the cost of inaction. Finally, economist Maria del Carmen Navarro, current technical secretary of CONAMUSA and former Horas CONU consultant, will present the challenges and obstacles, having participated as a consultant in the study of the cost of tuberculosis diagnosis within the framework of the project to strengthen tuberculosis laboratories in 17 countries, including the Andean region, which provides important evidence to be taken into account. We are also grateful for the presence of Dr. Leonid Leka, Executive Director of Socios en Salud, instructor of the Department of Global Health and Social Medicine at Harvard Medical School, and member of the MDR-TB Green Light Committee for Latin America and the Caribbean of the Pan American Health Organization. Welcome to Dr. Valentina Alarcón, Director of TB at the Ministry of Health of Peru. Once again, welcome. Thank you very much, dear Dr. Calle. After the greeting from our Executive Secretary, I would like to introduce myself. My name is Marianela Villalta, Coordinator of the Andean TB Committee at the Andean Health Organization. Today, I'm very pleased to be in charge of moderating this webinar. After this preamble, we extend a warm welcome to Dr. Ernesto Montoro. Dr. Ernesto Montoro is a doctor of medicine, graduated from the University of Havana, Cuba, specialist in microbiology with a master in bacteriology, mycology, and doctorate in medical sciences. He has more than 30 years of experience in TB. He was head of the National Tuberculosis Reference Laboratory at the Institute of Tropical Medicine in Havana and director of the PAHO Collaborating Center for Tuberculosis. From 2017 to date, he is working at the Pan American Health Organization in Washington, D.C. as advisor for laboratory integration. Welcome, doctor. The space is yours. Thank you, Marianela. I would like to greet Dr. Calle. Thanks to the organizers of Horas for inviting us. And I would like to share with you greetings from Pedro Arillo, who is the international advisor in Washington.
Como ya se indicó,
As it has been mentioned,
va a ir
our
a presentar cuáles son los
presentation
de la
will
reunión de alto nivel
show
de las
what are
Naciones
the
Unidas
challenges of the
celebrada el
high
pasado
level
año
meeting of the
sobre
UN
tuberculosis, la segunda
on
reunión
TB,
que
the
son
second meeting
aplicables a la región andina.
that are
Además que,
applicable
bueno,
to the
como
Andean
parte de la región
region
andina también a
and
nuestra
as
región
part of the
para
Andean
América. Sigue
region
la
to our
presentación
region
allí.
for the Americas. Can you see the presentation?
Así es, doctor.
Okay. Continúa entonces.
Okay, so I'll continue.
Sí. Entonces, bueno, mencionábamos ya que la pasada
We were
reunión
mentioning that in the
de alto nivel
second
de las Naciones Unidas,
high
reunión
level meeting of the
que trató
United
sobre el tema de
Nations
tuberculosis,
that
celebró
discussed
el
the
22 de
topic of
septiembre
tuberculosis that took place on
en la ciudad
September
de Nueva York,
22nd
Estados
in New
Unidos,
York,
donde
United States,
participaron más de 600
with
participantes.
more than
El resultado de
600
esta reunión de
participants.
alto nivel
The
fue la
result of
declaración
this
política,
meeting
una
was the
declaración
political
política
declaration,
concisa,
a
orientada
concise
hacia la acción,
political declaration
acordada de antemano en
oriented
consenso
towards
a través de
action that
negociaciones
was
intergubernamentales,
agreed by
donde
consensus through
más de 515
intergovernmental organizations,
declaraciones por
where
los
more
jefes de Estado
than
y de Estado y los
515
jefes de ministros.
declarations were made
Participaron
by
más de
heads of state,
125 delegaciones
ministers.
de ministros
More
y de
than
países con más
125
de 300
delegations were
participantes de la
present,
sociedad civil
more
y
than
5
300
agencias de las
participants
Naciones
from
Unidas.
the civil
Luego de
society
esta
and 5
reunión
agencies of the United
se acordó
Nations.
la
As a result
declaración
of this
política
meeting,
de lucha
there
contra
was
la
a political
tuberculosis que se
declaration
aprobó ese mismo día, el
about the
22 de septiembre,
fight
y
against
fue adoptada
tuberculosis
el
that
5 de
was
octubre del pasado año
approved on September
bajo la
the
resolución de las
22nd
Naciones Unidas.
and was approved
Si
on
hacemos
October
un
last year
progreso
as
o un
a UN
avance en
resolution.
relación a la
If
primera
we
reunión que ya
talk
se mencionó, que
about the
fue en el
progress made with
2018 del
regard to
periodo
the
hasta el
first
2022,
meeting
de
in
los objetivos que fueron
2018 to
trazados en esa
2022,
primera reunión
about the objectives
dentro
that
de los
were
objetivos
set in that first
relacionados
meeting,
con
we
el
see that the
tratamiento de la
objectives
tuberculosis establecidos en
related
esa
to the
meta
treatment of
es
TB
tratar
established as
40
goals,
millones de personas
treating
en
40
un lapso
million
hasta el año
people,
2022,
and
solo se
until
trataron 34
2022,
millones
only
y eso
34
corresponde a
million
un
were
34%,
treated,
un
which
84%.
represents an
Otro de los objetivos
84%.
es el tratamiento
Another
preventivo de la
objective was the
tuberculosis con
preventive
una
treatment
meta
of
de
tuberculosis
30
with
millones,
a
de los
goal of
cuales se cumplió el
30 million,
50%,
where
que corresponde con 15
50%
millones.
was
Otro
accomplished,
objetivo
which
fue
is
relacionado, que ya
15
se
million.
mencionaron
Another
anteriormente, los
objective
objetivos del
that
alto
was
nivel
mentioned
anual
was the
para
annual
garantizar el
financing
acceso a la
objectives to
prevención, al
guarantee the
diagnóstico y al
access to
tratamiento.
prevention,
Se
diagnosis, and
establecía como
treatment.
meta 13 billones, de los
The
cuales
goal
solo
of
se cumplió
13
un
billion was
44%.
established and
Y
only
los fondos destinados para la
44% was accomplished,
investigación,
and the
para la búsqueda
funds
de
destined
nuevos
to
métodos diagnósticos,
research,
nuevos
new
tratamientos,
diagnosis methods,
nuevas
new treatments,
vacunas,
new
estaba
vaccines
asignado o una meta de 2
was
billones,
set
de los
at
cuales solo
2
se cumplió el 50%.
billion,
Vemos que realmente
where only
no se
50% was
cumplieron los
accomplished. We
objetivos
see that
trazados
again, the objectives
durante
set
la primera reunión y por
during the
tanto hubo
first
una
meeting were not
afectación muy
accomplished,
grande en
and
los
there
últimos
was a
2 años
big impact
con relación
in
a
the
la
last two
pandemia del
years
COVID.
as a
¿Cuáles
result
fueron
of
los
the
compromisos de la reunión de alto
COVID-19
nivel de las Naciones
epidemic or
Unidas del
pandemic?
pasado
What
año,
were the
donde se
commitments of
establecieron
this meeting
metas
last year?
generales en
Where
materia de
global
tuberculosis que están
goals were
establecidas en
established
la
in TB
declaración
matters, which
política
are
en esta
established
reunión de
in
alto
the
nivel para ser
political
cumplidas en el
declaration,
periodo
this high level meeting, to
2023
be
y hasta el
accomplished in the period
2027. Se
from
mantiene el compromiso
2023 to
mundial de la
2027.
cobertura del tratamiento de
The
la
global
tuberculosis, de lo
goal
cual
with
se
regard to the
logró
coverage and treatment of
90%.
TB
Vamos a, en la
remains.
región
We need
estamos
to accomplish
aproximadamente en un
90%. In the region,
72-74%,
we have
según el informe
72,
mundial de tuberculosis
74%,
publicado por la
according to
OMS
the
en el
global
2022,
TB report
y el
published by
cumplimiento de un
WHO in
90% para
2022. And this
2027
accomplishment of
representa o equivale a
that we mentioned
45 millones de
represents
personas
to
en todo el mundo en ese
45
periodo. Otra de las
million
metas es
across the
establecer,
world during
como
this
ya lo
period.
dijimos en la
Another
reunión
goal
anterior,
was
la
that,
cobertura del tratamiento
as in
preventivo
the
de la
previous meeting,
tuberculosis, que debe
the
alcanzar
preventive
una
treatment
cifra
of
de un
TB
90% para
remains,
el
which should
2027, y
reach
esto equivale a 45 millones de
90%
personas
for
en todo el mundo.
2027, and this is
Además,
equal
la
to
cobertura de las pruebas diagnósticas
many million
rápidas
people,
recomendadas por el
and
organismo
also the
mundial para
quick
el
or
diagnóstico
fast
inicial
test
de la
for the
tuberculosis
diagnosis
debe ser
of
cumplida en un
TB
100%
initially
para el
must be
2027.
accomplished
Les puedo
at
mencionar, aunque se
100% for
probablemente lo vamos a
2027.
ver,
I can
que en el
mention this.
2022 la región de las
In
Américas solo
2022,
estaba en un
the
40%
Americas had
de
only
los
reached
casos
a
nuevos y recaídas en los
40%
cuales se
of the
había
new
realizado el diagnóstico con una
cases
prueba rápida
where
molecular.
diagnosis had
En
been
los
done
últimos años
with
vamos a
rapid
acelerar los
molecular
esfuerzos
tests.
para
We
poder
see that in
aumentar
recent years
esta
we have to
cobertura.
accelerate the
Otra de
efforts to
las metas
increase
es
this
la
coverage.
cobertura del
Another goal was the coverage of social and health benefits for people with TB, the annual financing of basic services for TB, which has to be 22,000 million for 22, and this research on TB that needs to be increased to 5,000 million, and also the goal of facilitating universal access to new vaccines against TB. We also see that with this last goal, prior to the UN meeting, WHO, and specifically the General Director of Dr. Pedro Acano, inaugurated the Accelerating Board of Vaccines Against TB to facilitate the test, the development and authorization, and the use of new vaccines against the disease based on the lessons learned during the response to COVID-19. Therefore, it would be the first world platform of multi-sector collaboration to facilitate the development and access to vaccines against tuberculosis. What is necessary according to the goals and objectives established in this last high-level meeting of the UN? Accelerate things. How? With a strong political leadership that includes international fora such as BRICS, G20, ASEAN, a multi-sector response, and the implementation of a multi-sector responsibility framework with accountability on the adoption of the multi-sector framework for tuberculosis under the leadership of high level among 70% of countries with a high TB burden. The global reports, the biannual reports to the World Health Meeting, and also to achieve a greater participation of the civil society and of the communities affected by TB, the contribution of the task force of WHO, and intensifying research and innovation. And with regard to this last priority, to accelerate research and innovation with regard to diagnosis, treatment, and the development of new vaccines, despite the fact that the investment in research and innovation is not optimal at this point. The number of diagnosis tests or methods in development has increased in recent years based on the recommendations of WHO and the use of new quick molecular diagnosis methods. And we can mention that up to September 2022, there are 26 drugs for the treatment of tuberculosis at different levels, at different assay levels. There are clinical tests that are being evaluated for the pharmacological regimes, and 16 candidate vaccines are being the subject matter of clinical assays. Dr. Calle already mentioned the situation of TB globally, and we will stress the situation in the Americas and also see what is the situation of the Andean countries. These graphs are very well known. They show the trend of the incidence and the number of deaths estimated due to TB, which represent the milestones and goals of TB that were launched from 2015 to 2035. We see that the estimated incidence of TB was 325,000 cases, including new cases, which represented 3% of the global total, and an estimated rate of 31 per 100,000 inhabitants. Between 2015, the start of the NTB strategy, and 22, there was an increase in the incidence of 20%. As you see in the green line, we need to achieve the decrease towards the milestone of 2025 to comply the SDGs of 2030, 5.4, and for the 2035 strategy
negativos que tuvo
2.7.
países en la
We
región
see
que
the
afectó
negative
Venezuela,
effects
por ejemplo,
in
del
the
COVID-19
region as a
en
result
2015,
of COVID-19. We see that in 2022, there has been a recovery in the notification of cases, but we are still in the process of achieving these goals. With regard to the number of estimated deaths, we see that the baseline in 2015, it was estimated that in 2022, 35,000 people died, which represents a rate of 3.4 per 100,000 inhabitants, and 31% of this was attributed to HIV, TB cases. There was an increase with regard to the baseline of 2015, and we see the green line below what are the goals that we should be achieving according to the milestones of 2025, the SDGs of 2030, and by 2035 we should reach a level of 1,000 deaths. We see what was the progress in 2022. There was a notification of 242,000. There is a gap of 83,000 people that were not notified, and 41,700 people were not diagnosed in the case of TB in the last 2 years, and this represents 74% when we need to reach by 2027 90%. We see the estimated incidence. We said 325,000 for the Americas region, and we see that 3 countries here, Haiti, Peru, and Bolivia, have a high rate, considering in this case a rate above 100 per 100,000 inhabitants, and these 3 countries represent 25% of the total cases. We see the countries circled in red, the countries that correspond to the Andean region, those countries with a high burden, Peru, Bolivia. The rest of the countries are in a moderate rate, less than 100 and more than 10 per 100,000. And we see that there are 14 countries that are at an incidence rate below 10 per 100,000. And these countries are the closest to eliminate the disease. Most of the countries in the region have a moderate rate, so there is a rate in the region of 31 per 100,000 inhabitants in the region. At the graph on the right, we see how the countries of the region, the ones with the highest notifications, are 3. 2 are part of the Andean region. Of the 242,000 cases notified in 2022, 30%, 1/3, corresponds to the Andean countries. Here we see countries with the highest burden. For 2022, we see that Brazil is leading with 105,000 estimated cases, 32.3%, and the rate would be 49. And there are the cases, Peru, Mexico, Colombia, and other countries with a high burden that belong to the Andean region. And I mentioned that from the 325,000 cases estimated, 35% correspond to the Andean countries. With regard to the number of TB cases or multi-drug resistant cases, it was mentioned that globally 400,000 cases of resistance are estimated, and we see that for the Americas, there are 11,585 cases, and we're talking about 5,444. And from these countries, 54% represents the notifications to these countries. We see that in the case of Peru, Peru is one of the countries with the highest number of cases in the case of drug-resistant TB cases, and also Peru is among the 30 countries that are drug-resistant countries. If we analyze the estimated cases of TB that are attributable to 5 risk factors, we can mention malnutrition, consumption of alcohol, HIV, smoking, and diabetes. Out of the total number of cases reported in vulnerable populations, we see that people that are in prison have a certain representation, 8.2%, children 4.1%, indigenous populations 3%, homeless people 1.9%, and immigrants 1.5%. The highest rates correspond to people in jail with notifications above the levels of notifications in the rest of the population. We see that the average for the Americas is at a rate of 518 per 100,000 inhabitants. And in the case of Latin America and the Caribbean, we're talking about 1,126. We are showing that in a red circle, the countries with the rates in the case of people in jail. With regard to the coverage of rapid tests recommended by WHO for the initial diagnosis to replace the conventional methods, we see that in 2018 the level was 18% and we reached the level of 40%. I consider that from 2021 to 2022 there was an increase in the number of tests carried out, and this was a result of the acquisition of countries in recent years of new equipment and in a higher number of tests carried out. We cannot be okay with this 40%. I was mentioning that the commitment of this high level meeting was to achieve a goal of 100% for 2027. Another parameter which is not satisfactory and is remaining low in recent years is the coverage of sensitivity tests in the case of rifampicin in the confirmed cases. We're only in at the level of 57% for new cases and 62% in previously treated cases, when these goals should be close to 100%. And this, of course, not only, as we mentioned in some presentations that we carried out, this not only depends on the acquisition of equipment of GeneXpert equipment that have been mostly used in the region and new molecular platforms, in addition to the purchase and sustainability of resources. This is not enough to increase this coverage. We need to have an efficient and cross-cutting sample transportation system, a connectivity of equipment that allows to transfer results in real time, timely results, and that this we need, in order to stop this equipment from being sub-utilized, they should be used with a multi-diagnosis platform. With regard to the results of the treatment, we see that the success of the treatment, both in these cases that we see, new ones, we see 22%, and for those below the age of 15, it's 76%, and is this lower in the case of XDR and MDR. We see that the highest percentages of lack of tracking pertain to XDR patients, and also in the case of HIV patients with TB. We need to accelerate the recommendations to adopt them with regard to the use of fixed combined doses of drugs, the adoption of new schemes for the case of sensitive TB and for drug-resistant TB, based on an oral system with a 6 month duration. Also, there needs to be a support based on individuals to improve adherence through integrated services for comorbidity and also social protection. To summarize this, what we have seen so far is that according to the region's estimates, out of 325,000 cases, there is a gap of 83,000 people without being diagnosed and 12% for people in jail, 16% of contacts, 24% refer to co-infection, and 47% in the population in general in hotspots. Also, 74% has been diagnosed, where the goal is, or the target is 90%, 40% of the use of rapid tests target 100% and 70% in the treatment success. We see that at present, only a percentage of people with HIV receive treatment, only 11% of the contacts, and also with regard to the application of selective and massive samples and the adoption of shorter regimes with social support based on individuals or centered in individuals, it is necessary to carry out the integration of the services with the multi-sector integration, the participation of civil society, and the response based in data to achieve the targets and milestones of the NTB strategy, with a reduction in the deaths from TB and the catastrophic costs of affected households at 0%. We mentioned that there are 17 countries that have an estimated rate, and we believe that this is a low incidence of tuberculosis, and these are the countries that are closer to eliminating TB. So, to summarize what we have seen so far, what are going to be the priorities at the regional level applicable to Andean countries to accelerate the efforts towards the elimination of the disease? We need to approach TB in vulnerable populations and the most affected areas. We need to apply the innovation, the new recommendations of WHO, with an active search with artificial intelligence, the preventive therapy, shorter treatments, the adoption of rapid molecular tests as an initial diagnosis, systems based on individuals. Also, there should be digital surveillance systems that allow us to analyze and use data. And of course, the multi-sector approach and involvement of civil society to serve the most vulnerable populations and the affected geographical areas. The following is proposed: a change towards a systematic filtering of TB in target populations. There are some experiences in Peru, Paraguay with the use of these technologies and digital innovations, digital X-rays with computer-assisted detection mechanisms, integrate the preventive treatment of TB and the filtering of other diseases. We also have to use systems for a thorough analysis of the situation in real time, carry out the mapping of these populations and high-risk geographical areas, and also the creation of charts and different analysis at different levels. To end up, I will show you the initiative updated by WHO, the updated list of candidates for elimination towards 2030. As conclusions, we require urgent actions to stop and revert the increase of incidents and deaths by TB and accelerate their response towards the elimination of the framework of the NTB strategy and the commitments of the new political declaration of the high-level meeting of the United Nations on TB of 2023. For this, the following is needed: to change the approach and strategic prioritization, strengthening the guidance and governance through an intense monitoring accountability, and focusing on actions at the local levels, accelerate the implementation of technological tools and innovations that may accelerate efforts towards elimination, and optimizing resources and look for efficiencies through the promotion of synergies and inter-programmatic collaboration in the framework of the health care. And we end up with the motto of the World TB Day. Yes, we can put an end to TB. Thank you.
Muchas gracias, doctor Montoro.
Thank you, Dr. Montoro. However, the figures that you have shown are very worrying. Even though the pandemic has favored research, vaccine development, the access to technology, nevertheless, there is still TB. There is a significant gap and the need to be able to use innovative technology and strengthen research. Our Andean countries are those that have the greatest burden and the greatest resistance in the case of TB. And afterwards, I will be able to make a question. When we need to accelerate response, yes, we talk about the leadership, we talk about the participation of the civil society that shows its influence, innovation and research, but I would like to stress this point: the multi-sector response, but it is not an isolated response because it is being placed in a framework of responsibility. And I would like you at the end of the meeting to delve on this topic. Thank you so much. You have stressed the vulnerability. There are people in jail, there are indigenous people, children, homeless people, and immigrants. You also mentioned the comorbidities topic, HIV. Thank you so much, Dr. Montoro. I am sure that there will be many questions in that. I hope not. I hope. Now, in order to talk about the cost of inaction, Dr. Montoro has told us or has shown us that the inaction has consequence, and this is at the state to talk about the cost of inaction in the case of TB. We would like to present a video from Dr. Luchika Du. She is Executive Director of Stop TB Partnership. She is a Romanian doctor, a leader in the fight against tuberculosis worldwide. Since January 2022, she is a director of this organization. Dr. Titi always repeats that we must leave no one behind, and she is one of the strongest advocates within the international community in the fight against tuberculosis. However, she always mentions innovation, flexibility, change, and innovation. Dr. D2 is dedicated to driving political commitment and engagement to accelerate efforts to end TB. She is in an event at this moment, and that is why she has sent us this video.
Hi, hello everybody. My name is Luchika Ditiu. I am the Executive Director of the Stop TB Partnership in Geneva, and I am greeting you in a recorded message, and I apologize for not being able to join live, as when you are there in the webinar, I will be in Manila, and the time difference made it very difficult for me to join live. It's always difficult to send a recorded message. I actually love in-person meetings. I love to be live and in touch with people, but it is a way that I hope it's a beginning of a great collaboration with the great organization, Andean Health Organization. I'm very, very impressed, not only with the organization, but with all the achievements since May 2020, with when I saw 200 webinars, 9 forums, and 5 international congresses. I think everybody there should be very happy and should congratulate themselves and yourselves for all these achievements. I want to give my special thank to Maria del Carmen Calle Davia as the Executive Secretary of the Andean Health Organization, as well to the other speakers in this forum, starting with my friend Pedro from PAHO. As you realize, we are from Stop TB Partnership, we are trying to push, pull, and gather all the efforts to be able to end TB by 2030. And it's a dramatic fact that even though we are in the year 2024, and tuberculosis is with us for thousands and thousands of years, we are unable to end it. We didn't end it so far. I think it's a failure of the humanity because, as you also know very well, we had diagnosis and treatment for TB for 100 years. For 100 years, we had as well ways to vaccinate. So, to be honest, it is in our capacity to at least go to much lower levels than where we are right now. Where we are right now, you don't need me to tell a lot about the global figures. I will just mention a few things about it. We are still at more than 10 million people infected with sick with TB every year. Infected with TB is a much higher figure. With estimates of WHO are that around 24 to 26% of the global population is infected with TB. So, depending how many are in the webinar today, 20 to 25% should be, according to these figures, infected. So a large pool of people infected with TB. As I said, more than 10.6 million people sick with TB in 2022. 1.6 million dying with TB every year. Number one infectious disease killer, overtaken just in the year of COVID, by COVID, obviously. Now we are unfortunately back to this leadership position. A very unpleasant, background that I'm putting here. As you might also know, not huge achievements on drug-resistant TB and MDR TB. Still a lot of people not diagnosed and not treated, and still half of people with TB are being diagnosed using the microscope, which is a tool that it's with us for more than 100 years. Everything evolved. We still diagnose TB with this old tool, even though we have rapid molecular diagnosis tools. So we have a lot to catch up. As Stop TB Partnership, based on the End TB strategy of WHO, we developed for the last 24 years, and we will continue to do so, 5 years plans, investment plans called Global Plans to End TB, in which we look at different packages of interventions that are put in place at what cost to be able to end TB. The latest global plan that we developed, the Global Plan to End TB 2023-2030, I think includes basically all the different aspects that will need to be put in place as a complete package to be able to end this disease. The global plan is a pretty large document, and I'm sharing with you as well the link to it, and it underlines all the different components from diagnosis, treatment, prevention, engagement of TB survivors, all the aspects around the stigma, rights, and gender. equity and inequities, as well as outlining the research that needs to happen and the tools that we should have to be able to end the disease. The global plan, but not only the global plan, shows what an important investment tuberculosis is. And I think everyone in the room, I am a pulmonologist, we know very well that TB is very cost efficient because the cost of the drugs and the cost of the diagnostics are not as high as what we get if people get early diagnosis and treatment and are getting cured. Because we know TB is a disease, obviously an airborne pandemic, exactly like COVID, that is evolving through and spreading. So the more we can diagnose and the early, the least transmission will happen. But groups like the Copenhagen Consensus and others did some very smart modeling. They are a group of economists that won a Nobel Prize in the Copenhagen Consensus, and they arrived at the conclusion that tuberculosis is in top 10 investments to reach the UN Sustainable Development Goals, and that for each dollar invested, there is a return of 40 other dollars. It's an amazing return for investments. It's very important to say, okay, it costs money, obviously, to address TB, but it costs much more if we don't. And when we speak about much more, there is a financial cost, which between 2023 and 2030, the cost of inaction will be $1 trillion to the global economy, to all the countries together, by not doing and not ending tuberculosis. But more important than the money is the cost of inaction related to the lives of people, because almost 7 million people will die of TB, and almost 50 million people will be sick with TB within this interval, again, 2023, 2030. So situation is actually not that grim, because what happens, at least what happened in 2022, 2023, and we as Stop TB are very much in touch with all countries to understand the status, is that countries are able to diagnose and treat more and more people with TB. According to the formal data of WHO in 2022, there was a very good year in which more people with TB got access to diagnosis and treatment. And from our own estimates in 2023 will be even better. We don't have yet the formal data as they come later in the year from WHO. But from the data that we really looked at countries and speaking with the country programs and the governments and partners, it looks like 2023 will be even better. And countries like big reservoirs of TB, India, Indonesia, Philippines, Nigeria, Bangladesh, South Africa, Pakistan, did a great job in getting access to diagnosis and treatment to more and more people. So from the entire pool of 10-point-something million people with TB, more than 8 million were diagnosed and treated in 2023, which is remarkable. We never had so many people from so many that are sick having access to diagnosis and treatment. We have, as you know very well, we have a lot of tools in the pipeline for diagnosis, very smart ideas. You have miniaturized X-ray with artificial intelligence reading. We have miniaturized molecular diagnosis. There is a test for using urine and see if it can be applied not only to people living with HIV, but people without HIV, and use a color spectrum to diagnose TB. There is an app that works on the phone to analyze the cough. There are many companies developing tools for diagnosis of TB. There is a lot, as you know, there is a shorter treatment regimen for normal TB, for drug-resistant TB as well. When I was a medical doctor, I would have never think that the treatment for MDR-TB will ever go to 6 months. As you know, we used to have 2 years with injections, very painful, a lot of side effects, very bad situation. Things changed, and we have a lot of hope to get a vaccine by 2028. So what I want to say in the closing of this intervention that I have is that we cannot afford to sit and look. We cannot afford to be quiet. We cannot afford to ignore what is happening, because this is a disease that it's airborne, you know. It's a disease that puts at risk all of us and our families and our children. And I don't think anyone in that room, ourselves included, we don't want to leave to our families, to our children, a world that is it still has tuberculosis in it. I think we need to, all of us, push to increase the awareness and the knowledge on what is happening with TB. And I think in your region, as I know very well, Pedro mentioned, and I know that the plans in PAHO, this region can lead the world to show that TB can be not only ended, but eliminated. I know that TB is not a huge burden in some of the countries that are represented in the Andean Health Organization. But as you know very well, and we have examples in the history, the most recent ones being in the US, starting even in '92, once is not properly done and ended, and transmission reduced to almost zero, it will come back because it's airborne. And nobody is safe. I know it sounds like a cliche till everybody is safe, because we circulate so much this time. So it's not enough. And we see that a lot in all these countries. You know, I live in Switzerland, but for example, I am infected with TB and I really don't know where I got it, right? I was negative and now I'm positive for TB infection. So I don't know very well where I got it. So there is, I assume, but there is nobody protected as long as we didn't protect everybody. And this is what webinars like yours and the work like yours is so important, not only for the concrete work on the ground, but for raising the awareness, raising the ambition, and the need to maintain TB on the agenda of health of the countries in which the TB might not be the top disease in that affects the people, even though here we have few of what we call higher burden countries for the region. But I know that you know, there are other priorities on the agenda. We are a Stop TB partnership. We are doing this year 6 regional meetings in every region. We do a meeting to really push not only for the awareness, but for something that I know is very important here as well, additional funding for TB. And we will plan one together with Pedro in your region as well, to really discuss not only how we can maintain TB on the agenda, but how can we increase the funding. Domestic funding is important, and it's important to make the case with the governments. But beyond the domestic funding, there is also possibilities, I hope, for some smart financing coming from the development banks and maybe from some of the bilateral donors. The time that investments just in TB are just for TB passed, we didn't do too much in TB like that. There were other diseases that were far more vertical. When we invest in the data systems, in laboratories, as you did with the project, in care, in making hospitals and dispensaries safer with proper infection and environmental infection control, that's good not just for TB. That's good for other diseases that are airborne as well as for, so therefore for all the people in your countries. So in this line, because the conversations this day around pandemic preparedness response, antimicrobial resistance are coming a lot, we need to make sure that TB is part of that conversations as well, as it can benefit as well from the investments in these areas. As you know very well, during COVID, the investments in TB were very useful, and the doctors dealing with TB and the nurses and health workers were very useful in addressing the COVID pandemic, as we all, I think, remember. I spoke more than my time allocated. I want to apologize for that. I think I know that the region is very vibrant, and I had the chance during our board in Brazil to meet several colleagues from parliaments as well as from the civil society from the region. I have a lot of respect for the energy and passion that comes from there. And I know that the region is not necessarily a darling of donors, but we from Stop TB, we will try to help from our side to change a bit this, narrative, and to have the region and to have the countries of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, as members of the Andean Health Organization at the forefront of eliminating TB. Thank you so much. And yes, of course, we can end TB.
Bueno, nos hubiera encantado tener a la doctora Lucica acá para agradecerle
We would have loved to have Dr. Lucica here to thank her for her excellent presentation. However, I think that we need to think about this. TB is here and we cannot ignore it. And it is not a cost, it is an investment. She has showed us the advantages about the early addressing this disease. If we do not do something, this affects not only the health of the population, but also the quality of life. And this is a social determining factor. Thank you so much for this video. Next, and in order to reinforce the title of this webinar, we would like to share the presentation of Dr. Meredith Brooks. She is author of the article Cost of Inaction, a Framework for Estimating the Economic Cost of Losing a TB Patient in the Indian Context. This is a very important article. Dr. Meredith Brooks is an assistant professor of global health at the Boston University School of Public Health. She holds a Master of Public Health in Urban Health and a PhD in Population Health. She also completed a postdoctoral fellowship in tuberculosis epidemiology at Harvard Medical School. Dr. Brooks is committed to improving the health and well-being of vulnerable populations globally. Her most recent research focuses on identifying interventions and strategies to improve the detection, diagnosis, and care of children and adolescents with TB or at high risk for TB. I invite you to listen to her presentation. Please, Rob. After Dr. Brooks' presentation, also for the corresponding questions, we have the presence of Dr. Leonid Leca, who is the Executive Director of Socios en Salud.
Hi, everyone. My name is Meredith Brooks, and I'm so thrilled to have this
Me
opportunity
siento muy
to speak
contenta de
with you
tener esta
today and to
oportunidad
share mine and my colleagues' work on the cost of inaction, a framework to estimate the economic cost of missing a patient with tuberculosis in the Indian context. I have no conflicts of interest to declare. Every year, we highly anticipate the World Health Organization's annual Global Tuberculosis Report to update the TB community on the progress in the previous year. Although global trends in TB incidence have been slowly declining for years, interruptions due to the COVID-19 pandemic led to the first uptick of incidence in years. Notifications also dropped substantially, but are beginning to rebound again. We remain significantly off target to reach the milestone for 2025 as set by the WHO NTB strategy, not even 1/5 of the way to meeting goals for TB incidence rate reductions, 1/4 of the way to meeting TB death reductions, and about halfway to reducing the percentage of people with TB facing total catastrophic costs. So how do we push forward to meet these goals and surpass them on our quest to eliminating TB? Well, modeling studies show that the greatest impact to drastically reduce the number of individuals with TB is a combination of strategies, including both treating active and latent TB. The Zero TB initiative was created in 2016 with the goal of creating islands of elimination by supporting local coalitions against TB. Partner sites commit to use a comprehensive approach for epidemic control by utilizing all components of a search, treat, prevent strategy. So what exactly is a comprehensive approach to eliminate TB? It comprises 3 distinct phases that all work together and need to be implemented at the same time within a community to demonstrate full benefits. The first component is search, in which we should actively search for TB and use appropriate testing to screen individuals accurately. The second component is treat. When we find an individual with active TB, we need to treat them effectively with an appropriate drug regimen and support them through to treatment completion. The third component is prevent, in which we aim to mitigate exposure and treat individuals who are exposed to prevent progression to active disease. We often say that we know how to conquer tuberculosis. We have evidence-based strategies that work, but outbreaks in poor countries are not treated in the same way as those in rich ones. The Zero TB initiative has pushed beyond the cynicism to forge a new consensus toward effective, comprehensive, and compassionate TB elimination efforts. There are numerous historic examples of successful implementation of a comprehensive approach to care, driving down TB rates. My first example, in the 1950s in Alaska, there was a local TB prevalence of 2,000 per 100,000 population, and a mortality rate of 282 per 100,000 population. A quarter of infants were infected with TB within their first year of life. For a decade, the U.S. Public Health Services built health facilities and the three components of a comprehensive approach to eliminate TB: active case finding, treating all forms of TB disease, and treating TB infection to prevent disease. This figure demonstrates the remarkable drop in annual risk of TB infection among children during this time period from 25% to almost nothing at all. And here we see the overall drops in TB incidence rates, a rapid drop when the comprehensive approach was implemented in the 50s and 60s, and the maintenance of low rates have persisted for decades afterwards. A second example is from Russia. In the 90s, Russia had an emerging multi-drug resistant TB epidemic, very high rates of incarceration, detention, alcoholism, and unemployment. They had discontinued some of the effective components of Soviet-era community-based TB control, and they had a very fast-growing HIV epidemic. A comprehensive strategy was implemented in the Tomsk region around 2007, and again, within several years after, we observed a stark decline in the TB incidence rates. For a final example, I'll turn to Peru. With impressive decreases in mortality and incidence in the 1990s, the rate of decline began leveling out and had stalled. So, parts of Lima began employing a comprehensive approach in 2018, along with linkage to treatment and support throughout to improve treatment outcomes. A new active case finding approach was implemented to address the search component of the comprehensive strategy. Mobile TB screening units were employed across high-risk communities and, in some areas, led up to 10 times the prior estimated incidence rates from identifying undiagnosed TB in the communities. Now that we all agree that implementing a comprehensive approach to care is the best way to drive down TB rates, let's talk money. How much does a comprehensive approach to TB elimination cost? Because if everyone could afford to do it, why wouldn't they? The evidence is there. Perhaps a better question to ask is, can we afford not to do it? First, we need to shift expectations of what a successful program looks like. A successful program may not just lead to immediate declines in incidence. In fact, we expect multiple phases. First, a surge. As active case finding efforts get underway and more sensitive tests and algorithms are used, more individuals More individuals with active disease will be found, causing cases to peak. The second phase is the drive down. Once more cases are found, treatment of all forms of TB, plus treatment of those who are infected, will begin driving down rates by breaking local chains of transmission and preventing progression to active disease. We then have to work a bit harder in the middle and end phases as more resources may be needed to find less people in the community, but eventually the rates will decline. So how do we get TB programs to invest in a comprehensive approach? The issue is that benefits of implementing a comprehensive program are difficult to see in just a year's time, which is the typical budget cycle for most TB programs. And as we all know, TB programs want to see impact based on the interventions they're investing in. Benefits for comprehensive programs, Benefits for comprehensive programs are observed over a longer period of time. Here we see the red line, which shows a standard, somewhat steady budget for a TB program year to year. The issue with that is we aren't seeing the progress towards TB elimination with this investment. Now, with the blue line, we can see that the initial investment in a comprehensive package is more expensive upfront, but within several years, as we drive down TB rates, the investment in TB activities will also drop. So how can we make others see these longer-term benefits of an upfront investment in a comprehensive program? In fact, even the economists identified that investment in reducing tuberculosis should be a no-brainer due to the incredible benefit per dollar spent that could go towards reaching global targets of disease reduction. Because the long-term benefits of a comprehensive approach often get lost during annual budgeting sessions, we set out to better understand the cost of not implementing a comprehensive search, treat, prevent strategy to stop the spread of TB. Specifically, we aim to estimate what a single missed patient with TB will cost, also known as the cost of inaction. We do this in the Indian context. While this framework can be applied to other geographic areas, the assumptions would need to be slightly tailored in other settings. We take a crude approach to define the direct and indirect economic burdens. First, the direct cost of loss of productivity is estimated as days of wage lost from time away from employment. Second, the direct cost of diagnosis, medicine, and medical services are estimated. And third, we consider indirect costs associated with the contagious nature of TB. TB costs are not just incurred for the individual with TB, but for the people they further transmit disease to in the future. We take direct and indirect costs of 3 different groups into account: individuals who are diagnosed with drug-susceptible TB, those diagnosed with drug-resistant TB, and individuals who have TB but who are never diagnosed. Of course, these do not represent all potential scenarios, but we're aiming for crude estimates, so we decided to not get much more nuanced than these 3 categories. For people who are diagnosed with DSTB, we make several assumptions, all drawn from local literature from India. We assumed a daily minimum wage and 25 working days a month. We assume a 9-month diagnosis delay due to not seeking appropriate specialist care, inclusive of 6 months to be initiated on an appropriate treatment regimen. During this delay, we assume a 20% loss of productivity. During the first 3-month treatment period, we assume a 40% productivity loss, while during the last 3-month period, we assume a 20% loss. We also assume 40 half-day hospital or clinical visits, leading to 50% productivity loss during those days. And finally, we assume 10% of a support staff's time for assisting patients during 6 months of treatment. Next, for persons diagnosed with DSTB, we consider the direct costs of diagnosis, medicines, and medical services. We assume a cost of a standard 6-month DSTB treatment course per WHO recommendations using estimated body weight for dosing. We also consider costs for specialized care and diagnostic tests. We assume the time of a doctor, including several full visits and many short visits during treatment, time for other technicians, cost of 2 x-rays, and at least 4 sputum-based diagnostic tests or others. Lost productivity is assumed to be even more substantial for a patient with drug-resistant TB. We assume the same 9-month diagnosis delay at 20% lost productivity during this time. We then assume 70% and 30% lost productivity during the first and second half of treatment. We assume 80 half-day-long hospital or clinical visits throughout treatment, leading to 50% productivity loss for those days, and again, 10% support staff time during treatment. For persons diagnosed with DRTB, we use estimated values for the treatment of MDR-TB for WHO recommended regimens. Using the same cost per service, we assume a patient with MDR-TB requires more full visits with a doctor, more of a technician's time, more x-rays, and additional tests needed for evaluation and for diagnosis. Individuals who have TB but who are never properly diagnosed are at high risk of death. We assume decreased productivity over a 3-year time period, with 20%, 60%, and 85% losses in years 1 through 3, respectively. We assume 15% of individuals will spontaneously cure by year 3. We conservatively account for 10% productivity loss for a caregiver during this 3-year span. Individuals sick with TB but who are never diagnosed may eventually seek medical care for their symptoms, or if they are misdiagnosed, they may consume other medications. While care and medication costs could be large, there's likely great individual variability. Therefore, we conservatively assume that the cost of medicine is half that for drug-susceptible TB. Additional costs may include doctor's visits for symptom management or misdiagnoses, and other non-TB related clinical or diagnostic testing. Because of the great variability of these scenarios, we assume half the cost of that for individuals diagnosed with DSTB to remain conservative. Indirect costs also need to be accounted for because TB is contagious through airborne transmission. People with active TB can infect 10 to 15 people through close contact over a year, and those infected with TB have roughly a 10% lifetime risk of falling ill with TB. We use 3 conservative scenarios to calculate indirect economic burdens. Scenario 1 assumes 10 people are infected and a 5% risk of progressing to TB disease. Scenario 2 assumes 10 people and an 8% risk. And scenario 3 assumes 15 people and a 5% risk. These will provide conservative lower bound estimates. We then go on to estimate the number of people that a single person with TB will spread TB to. In step A, we calculate the number of new cases of DSTB based on the number of individuals infected and their percent risk of progressing to TB disease. Each of these new cases will go on to infect more individuals, each with a risk of TB disease progression, per the 3 scenarios previously discussed. We then calculate the total number of people infected from a single person with TB in step B. We do the same thing for DRTB for steps A and B. We assume that 95% of individuals with TB will have DSTB, and 5% will have DRTB per local epidemiology. We assume that 60% will receive TB treatment. We then calculate the economic burden that any additional individual infected with TB will cost the health system in steps C, D, and E. For step E, while we assume that DS and DRTB spreads to others at the same rate, we assume that an undiagnosed and untreated individual with TB spreads TB at a rate 3 times that of an individual who received appropriate treatment. This is, again, might be an underestimation and a conservative estimate. In step F, we then calculate the total cost for patients diagnosed with DS, DR, and not diagnosed at all by summing the direct and indirect costs for each. Finally, in step G, we calculate the cost savings of finding someone with TB who otherwise would not have been found. Here we see the cost breakdowns in US dollars of direct and indirect costs for patients found and diagnosed with DS and DRTB, as well as those who have DS or DRTB but who are never found or diagnosed. We see the three scenarios for indirect costs to account for differential further transmission, and we sum the direct and indirect costs to see total costs. So a diagnosed DSTB patient can cost the health system between $2,500 and $7,600. A diagnosed DRTB patient will cost the health system between $6,800 and $16,700. Meanwhile, a person with DSTB who goes undiagnosed will cost the health system between $8,000 and $23,500. And the person with DRTB who goes undiagnosed can cost the health system between $12,700 and $42,300. And I remind you, these were using conservative estimates. Now, the cost that a program would save by finding a single patient with DSTB who would not otherwise have been found ranges from $5,500 to $15,800. And the cost saved by finding a single patient with DRTB who would not otherwise have been found ranges from $5,800 to $25,500. And this can accumulate fairly quickly. Instituting a comprehensive TB program that identifies more individuals with TB, such as 100 individuals with DSTB, can save up to $1.6 million and $2.6 million for each 100 individuals found with DRTB. For every 1,000 individuals with DSTB found, the program could save up to $15.8 million and up to $25.6 million for 1,000 DRTB patients found. Obviously, the more individuals with TB found early in the process, the more savings that accumulate. So the main takeaways here are that a comprehensive search, treat, prevent strategy can effectively lead to a drastic reduction in TB. Investment into a comprehensive program can save healthcare systems millions or even billions in time. And a comprehensive care approach to eliminate TB is a profitable business model that stakeholders need to invest in. Overall, controlling TB is a profitable investment. We need to invest to end TB and save lives. I would like to acknowledge my colleagues for this work, Vishy Pengali, Tom Nicholson, and Salman Keshavji. And of course, the Zero TB Initiative for continuing to pursue comprehensive care approaches globally. Thank you. Please see my contact information in the bottom right corner. Feel free to reach out to me personally with any questions you may have. And thank you again for the invitation to share this work with you.
No, nosotros, muchas gracias. Igual quisiéramos tenerla
Thank
aquí.
you so much. We would like to have you here to express our gratitude, and the figures are clear, they are evident. We need to have an early intervention because this represents a substantial savings. And this represents health for people, quality of life, and that is a fundamental topic. Thank you so much. I'm sure there will be questions in this regard. We would like to round up this approach. The doctor has told us about an early intervention, the possibility of quantifying this and disseminating this information with the decision makers. I would like now to introduce Maria del Carmen Navarro. She is an economist, doctor of economics from San Marcos University. She has a master's degree in business administration in ESAN with professional training in Chile and Panama. She is a researcher in the social and economy areas in Indicadores and Centro de Proyectos Índice. She has worked at the Ministry of Economy and Finance in Peru, and she has worked as an advisor and consultant in various governmental and international instances. She has vast experience in auditing and teaching. Maria del Carmen Navarro has been a consultant for economic studies in the framework of the program Strengthening Tuberculosis Laboratory Diagnostics in the Americas region, approved and financed by the Global Fund, and whose objective is to contribute to improving the quality of TB diagnosis in laboratory networks in the Americas by strengthening installed capacity in the region. This project was executed by the Andean Health Organization as principal recipient and with the Executive Secretariat of the Council of Ministers of Health of Central America and the Dominican Republic, SECOMISCA, and the Pan American Health Organization, PAO, who as subrecipients. We are sure that with the presentation of this result, we were able to round out why quantifying inaction will lead us to serious consequences. Go ahead, Maria del Carmen. I will share the presentation. Please confirm that it can be seen. Okay. I am the last person to speak, so I will try to be as brief as possible. We're talking about the cost of inaction, and I would like to reinforce what the Executive Secretary of Orascona said. The cost of inaction is not the cost of doing nothing. It is the cost of not doing something in particular. I would like to refine the concept of costs. Probably those who work in the public sector define this in some way. The cost as we are approaching it in these studies is not equal to the cost, expenditure, budget, or monetary disbursement. When we talk about this, we stop spending at some point with a view to satisfying the needs of future generations. So what we need to see in this definition is that when we're talking about cost, cost is equal to sacrifice. That would be our definition based on this very important topic, which is investing in health. Having defined this, I would like to present this scheme that was developed by Stop TB. In the case of stigma, this shows us the path of TB, the path that people infected with TB go through. They start recognizing the symptoms and then they go through the diagnosis. Basically, the part that I would be looking at is the one related to the diagnosis part. Since the studies referred in the framework of the strengthening of laboratories and in the national networks, but I wanted to show you this model. In this topic, which is the stigma faced by people with TB that sometimes is analyzed when people lose their jobs, but there are other ways to conduct the cost analysis. And I have seen that in the previous study it was not considered. And a topic that has a great impact is mental health. I see that that has been included in other studies. So what we're going to see now is the results of two studies that were carried out in the framework of the project mentioned by Marianela. Establish the cost effectiveness of quality assurance of TB and DRTB diagnosis to achieve the 2030 targets of the NTB strategy and establish the cost of operating the supranational tuberculosis reference laboratories to determine sustainability. Then we have the methodology, the review of TB. The many countries comprised by the report, and then there was the review of control rounds. We're talking about countries sending panels and diagnosis, improve the efficiency of laboratories. The main assumptions are the cases not detected based on PAHO estimations, and this compares the notified cases during the pandemic. This percentage increased significantly. This data that I am showing you is from 2018, but according to what we have been seeing in previous studies, we are recovering. The other data have to do with the statistical data from the 20 countries where the pulmonary TB represents 85% of the cases. Sensitive TB, 95.76%. We saw that false negative represented 50% of the error, false positive 50% of the error. The failures, the percentages that you can see, the lost to follow-up, dropouts, complications at the emergency 5%, hospitalization 0.95%, ICU, and the sequelae, which we also consider the most important ones, were not analyzed on a cost basis. We had sensitive TB and MDR TB. And to stress what the previous doctor mentioned, in the risk of getting sick, the definitions that I could give would be that it is permanent, pernicious, and of slow development. It was not like COVID, where there were many cases in a very short period of time. The case of TB, 3 people during a year will infect 4 people, out of which 2 will fall ill and the other 2 will fall at any time in their lives. So in order to systematize this, in this chart, what we can see the estimation of what happens with a single case that is not treated. This is the result of the contacts. We're looking at 33 to 50 people, an average of 42 in the case of COVID. More clearly, if a person was in a plane, those exposed were the other passengers. In the case of TB, we're talking about the family, the people around this person. Those that are not infected from these 42 are 70%, and 30% are those who are infected among the people that were exposed. Out of this 30%, this remaining 30% develops a latent infection, but there is a delayed disease in the case of 10%. So if we look at this on a 100% basis, a person without treatment during a year, it would be 0.5, and in the next 2 years, or 65% of people at any time. This late disease or delayed disease, according to recent literature, if they could develop more serious diseases. For instance, the development of comorbidity and other topics that can diminish the defenses. Basically, the study that we developed was a solution based on an adaptation of a report from the UK. In the case of the antimicrobe resistance, there was an abstraction. We know that there are several diagnosis texts. There were 3 categories. The one that is carried out in all countries, and probably we'll turn about the BK. In the case of bacilloscopy, we have the gold standard, the culture test that takes longer, and finally the rapid tests. So for the study, as I mentioned, has to do with the quality of the diagnosis, has to do, we did this abstraction that has to do with this diagnosis. And on the right-hand side, what we can see is the number of days that the person takes before receiving the treatment. This has to do with two topics. One, how long does it take to have the result after the diagnosis? The other part has to do with the days where the body reacts to the treatment. We have read in the literature 15 days. In recent literature, less or less, a shorter period is mentioned. We have considered conservatively these two data, one that has to do with the time it takes to stop transmitting the disease to the other persons and the time to get a diagnosis. When we have the BK, the people do not react to the treatment and a new diagnosis where we have the cultured information, and there is a more significant delay up to 3 months. I wanted to show you here the type of tests that we identified in the 20 countries and that we added in the 3 categories. The one that was mostly used was the culture ones and the molecular methods. So, considering the number of cases that take place in the region, we and the number of people that are diagnosed by each of the categories that we mentioned, we have that as a result of these delays and this time without knowing what the diagnosis is, results in 6,700 cases. That would be with the level of efficiency of the laboratories. So basically, what is the message? Is to have diagnosis tests that allow us to know the results in advance, and that is related to the molecular tests. And then we could talk about the criteria for cost effectiveness analysis. There is symmetry between benefits and costs. If we avoid the cost, we have a benefit, and the benefit will be referred to the number of people that have the disease. In the direct cost, we consider treatment, complications, sequelae, in a limited way, out-of-pocket costs. Indirect costs, mainly due to loss of productivity. We have the alternative one, the current efficiency, and the alternative with which it was compared was the efficiency loss by method at 0.5%. So the avoided cost would be the difference between the cost generated in the two alternatives. What does this mean? If efficiency is lost in the diagnosis, there will be more new cases because these people will not have the accurate diagnosis and the appropriate treatment will be delayed. So in both cases, the avoided cost is calculated as a function of false positives and false negatives. Because of time constraints, I will not give you all the details, but these are the concepts that were considered as direct costs and indirect costs. Here, something that I did not mention was among the costs that we have, if they are less cases, there is a reduction in economic subsidies in those that are part of the social security system. That happens in countries where most people are insured, such as Brazil. In countries such as ours, the impact is lower. We have the two categories, bacilloscopy, and the other categories were merged, where 0.5% of effectiveness is lost, or there is a bigger error, and there is a percentage of error. And also considering this new alternative that we considered the results of this study is that in alternative one, which is the current situation, a total cost of 4 million, and in alternative two, where there's an error, is 5,600,000. The incremental cost due to having lost efficiency or having had a misdiagnosis is 1,300,000. And in alternative one, we saw that there were 600 TB cases, and in the alternative two was 783. The difference is 183 that were avoided. And this is done in order to appreciate if efficiency and the quality takes place. New TB cases would be generated and they would transmit the decision. We needed to compare this as a result to see what the benefit was. We take the investment or the cost of strengthening the supranational laboratories, which is another study, but I am talking about this right now, the relationship between the cost, the benefit avoided. We have a result of $7. There is a return on investment. For each dollar investment, there is a return of $7. So here the summary is that in the current situation, as you know, there is a delay in the diagnosis due to the different diagnosis in the countries. We have 600 new cases, and if there was a mistake in the diagnosis or a loss of efficiency, we would have 783. The cases avoided, if we maintain the same efficiency, would be 183. And what we would stop spending would be 1,300,000. So the cost for each country, the cost avoided for each dollar invested would be $7.72. This number needs to be reduced because it is the current situation. How? With a continuous improvement in diagnosis through different methods that the countries could be adopting. I will go back. We have the scheme that we used. There are several sources where the new cases appear. One first source is for the undetected cases. The difference in cases estimated by the PAHO and those that were not detected are 24,000 and 4,000 for TB, DRTV, and we have unidentified ones, and the people continue moving in the community. We have almost 30,000 new cases, and the next source is pulmonary, notified pulmonary TB cases. This study is based on pulmonary TB cases due to the delay in the diagnosis, the methods used in the countries. We have a total of more than 6,000 cases, and as a result of the loss of follow-up, we have a total of more than 11,000. We have cases of at a level of 24,000, and that would be the current status where the detection is not told. Now I would like to link with the operating cost of laboratories, which we were looking at to define why we were talking about $7. The Andean Organization project tried or dealt with the strengthening of laboratories. Laboratories in countries have a local laboratory network which are closer to the community. It could be from the second level of assistance and the national laboratories, the more specialized in the country. But these are assumed for a quality control or assistance. They work with the supranational laboratories that in 20 countries are Mexico, Argentina, and Chile. Peru, depends on the Argentinian supranational laboratory. Here we can see the different levels of laboratories, the different functions that they perform, more specialized in the laboratories, but the number of laboratories, the pyramid that you're seeing, we have more at the local level. The project dealt with the strengthening of supranational laboratories and how to improve quality. So when was the cost structure determined? When it was determined, it was seen that 80% of the costs were related to the evaluation of quality that allows us not to reduce efficiency and having less misdiagnosis, technical assistance with national laboratories, and disseminating biosafety and quality. Those would be the main costs. If we analyze this based on the expenditure category, we see that almost 60% are remunerations or compensations. I think that this is the most important resource because it is very difficult to replace the specialization. And here we have the technical assistance with supranational laboratories. There are different internships. They have to be in person. So there was a setback with COVID. And finally, let me mention the funding gap in the case of supranational laboratories to maintain the quality of diagnosis. This does not mean that at the national level, each of the country only work for the strengthening of their national laboratories, but the emphasis of this presentation that is related to the project developed in these 20 countries was to try to have or to reduce the number of errors in the diagnosis. This leads us to think that there should be research referred to diagnosis and that the countries implement the methods that are available and that are faster. And that would be the end of my presentation. Thank you, Marianela. Thank you so much. And we need to applaud the evidence. I think that the clearest conclusion is that we need to continue strengthening the laboratories because of the important role they perform. We have talked about the diagnosis, the timeliness, and laboratories play a vital role. We talked about diagnosis, quality, human resources in laboratories. Thank you, Carmen, for giving us information on the well-being of people. We are talking about mental health as well. And this also includes stigma and discrimination. We need to thank at this point all the people that have joined us today. We have people from Argentina, Belize, Bolivia, Chile, Colombia, Cuba, Ecuador, Spain, Guatemala, Paraguay, Peru, Uruguay, Venezuela, among others. We have received many greetings and many questions. To begin this dialogue based on the questions made, but I will ask you to switch your cameras on. There are many questions. Sometimes we're not able to answer them all, but we will take them into account. These webinars lead to a dialogue, technical meetings, and analysis as a result of this space. And now, let's begin. We talked about the importance of having an approach, Dr. Montoro. Dr. Valentina is here. She's the director of the TB control here in Peru. Welcome, doctor. We have Dr. Leonid Leka, Dr. Kusinovic, who has been part of the coordination of the laboratory project. We have all the team from Orozcano. We have talked about this important approach, a comprehensive and integral approach, strategies in the search for patients to carry out a timely diagnosis, treatment, and prevention. I have a question for all. What are those limitations that you see for this application? And above all, to disseminate this, the cost of inaction and reaching key stakeholders. I think that Peru is an example, a pioneer country in the region that is targeting an active search with the recommendations of WHO addressed to vulnerable populations. You were mentioning when I finished my presentation, you talked about the multi-sector approach. The TB is defined by the NTB strategy. It should not be looked as an inherent disease. We need the participation of all the sectors of society and, of course, the active and significant participation of the civil society that can be great advocates for the implementation of these new recommendations. So, as was mentioned, Peru is an example, and in addition to the external financing, it is also about guaranteeing financing with local budget and sustainability. Once the donors leave, the external donors that were for many years in the countries, and be able to have this national budget to maintain sustainability in actions in order to maintain what has been achieved. That would be my answer to your question, and I give the floor to other colleagues. Good afternoon, everybody. Well, I would say that there were three important components. The health service. It was mentioned that there is a need to have available services with infrastructure, with human resources, laboratories that are ready to provide the service. The second component is the component related to the recognition of TB social impact. And then we're talking about other public services, social protection services, housing programs. We have challenges here. How do we relate this with the health sector if it is a disease? And in theory, there is a multi-sector approach. And the third component would be the community. We need to recognize, it has been said in the presentations that not all TB cases reach the services. So there is a component where we have to search for them, probably the most vulnerable groups or families, as we say, have not even reached a health service. So this approaches of having an active search, finding the cases and bringing them closer to the health services is very important. We have the role played by people who know how to reach these groups with more information. We have seen that this highly contagious disease needs an early diagnosis, and evidence shows that if you have an early search, you will have more possibilities. In Peru, we have an important percentage of TB cases that do not even show symptoms, 13, 14%. So all of this is key. The concept that we had in the past about TB, waiting for an asymptomatic patient, this has changed. We need to put this forward and see how to implement these innovations. Thank you, doctor. As an economist, what I have to do is to review the literature. And after conducting this study, and also as a result of a meeting with Dr. Caminero, some very important issues that have emerged. It seems that the cough is less frequent and physicians are compelled to provide a treatment without having a positive bacilloscopy. That could be a question for the doctors present today. Another topic that I found in the literature is that an early diagnosis has a direct relationship with the reduction of sequelae. So the impact of sequelae that sometimes do not appear as a cost of TB per se, but in other services, there would be a reduction in this case, in the case of an early diagnosis. Carmen, it has to do with the cost. Sometimes as a health personnel, we have a specific interpretation, but when I want to position cost benefit, what strategy do you see? What are the main limitations that you find? We have talked about the impact. We want short-term impact when we're talking about a regular work, and this is a limitation. And also, for you, which strategies could we implement to make this situation visible in the case of costs? I don't know, Ernesto.
Te cedo la palabra, que tú eres la especialista.
I give you the floor because you're the specialist.
Sí, además de los estudios bueno, que tú has
In
realizado y
addition to
participas
your
con
studies
documentos,
and the ones in
mencionaste,
which
y
you
yo lo dije en mi
participate,
presentación, que una también
I
de los
mentioned in my
importantes o de las
presentation
metas
that one
era
of the
lograr
goals or
que
targets,
cero,
important
cero
targets,
porcentaje
was to achieve
de familias y hogares afectados por tuberculosis. Para esto existe
zero
una
families
metodología
affected
recomendada por la
with
OMS para la
TB. There is a
hiperprevalencia
methodology
en las encuestas
recommended
de costos
by
catastróficos. Y sí
WHO
tenemos varios
in the
ejemplos
case
en
of
años
studies
anteriores
for
de países
catastrophic
que
costs.
han
And we have
finalizado estos estudios. Y por
examples of
supuesto,
studies in countries that have
contribuyeron mucho
finalized
a la abogacía, ¿no? En
these
este que se
studies,
necesita
and this
con ese
contributes
liderazgo
with
político y sobre todo para actuar ante los
advocacy.
determinantes
We
sociales que
need this
afectan esto. Así es que
political
con toda esta teoría
leadership
del abordaje de la
because
enfermedad
we need to
multisectorial y
approach
donde
this
participan todos
disease
los
from a
sectores de la sociedad.
multi-sector
Entonces, podría
point of
mencionar los
view
estudios que se han
with the
realizado en
participation of all
Brasil,
sectors of
que se ha aprendido
society.
de mucho,
I
en
could
Colombia,
mention
lo han
studies in
realizado
Brazil,
recientemente
Colombia,
en China y otros están
Argentina
también
more
por
recently,
finalizar, como es el caso
and
de Paraguay,
others
Salvador también
are
lo hizo.
about
Y
to be
son
completed
estudios que
in
yo pienso
Paraguay
que en
and
el caso de
Salvador
Perú,
as
sé
well.
que tú eres una de las
I
especialistas en esto,
think
probablemente
that in Peru, and I know
realizar
that
ese
you're
estudio, ¿no?
interested
Quisiera comentar, bueno,
about,
y te cedo la palabra como
you're
para que
interested in
agregues
doing this kind of studies. So
amplíe
I'll
mucho
give
más.
you the floor
Sí,
so
yo
that
creo
you
que
can
esto es
elaborate.
bien importante.
I think that this is very
Nosotros, si bien
important.
se hizo
I
una,
think that even
una
though
intención, pero no se llevó
there
a cabo
was
a completar, ¿no?
there was
Esta necesidad.
the
Yo he
intention,
estado en el Ministerio de Economía y
but
en el
this
Ministerio de
need was not
Economía se llaman
materialized.
cuentas de
I
evidencia,
have worked
no
at
un
the Ministry
presupuesto, ¿no?
of
Entonces, es esa
Economy,
necesidad que
and
dice
if you
Ernesto,
do
más aún
not
si está
produce
en uno de
evidence,
los tres
they will
objetivos,
not
¿no?
allocate
De
funds.
alto nivel,
So as Ernesto said,
en todos los países. Yo
these
conozco,
are
me ha dado la
high
posibilidad
level
conocer porque hasta donde
objectives
yo vi en el reporte
in many
mundial
countries.
tenía
As
El Salvador y
Ernesto gave
Colombia,
me the news,
18
I knew
catastróficas,
about
¿no?
Salvador and
Así es.
Colombia
Entonces,
and Brazil.
de esos estudios concluyen
So
que más del
these studies
50%
conclude
de los
that more than
pacientes experimentaron
50%
costo catastrófico, ¿no? También creo
of
que lo mencionó
patients
la doctora
experimented or
Carmen,
experienced
que cada
catastrophic
país
causes
tiene que
was mentioned
estudiar
by
esto
Mari Carmen.
para la realidad. Yo
We
creo que
should
es un
have this
esfuerzo
for
que se
each
tiene que
country.
hacer
I think that this
y
is an
esto es la
effort that needs
evidencia,
to
¿no?
be
Que nos
done, and
permite
this is
que pueda haber
the
esa
evidence
asignación. Y lo otro, no dejar de
that
lado
allows
también
us to
lo
have
que
that
mencionó después Leoni
allocation.
también, en este
And
trayecto
I
de la
think that
altura que
Leonid
estuviste en
mentioned
uno
that
que hicimos con
in the
Leoni, ¿no?
case
Con
of
socios en
the
salud, se hizo
stigma
también
study, we did
en varios
that with
países, el
Leonid
proyecto
in the
fue
case of Socios en Salud.
breve,
This was done in many countries. It was seen that before the diagnosis, there were the symptoms and the social factors that are barriers to accessing help or assistance. This doesn't have to do with the ministry. The person needs to have the multi-sector assistance. Epidemiological studies show that TB went down when the economy improved in Europe. We have identified already the hotspots, and there is the need to have social protection schemes in those areas before TB strikes. So we need to generate the evidence in each country. And in some countries, the decision makers say, but that happens in other realities. So I think that each country has to generate their own evidence. Thank you for participating. Thank you. I would like to congratulate the speakers, and I would like to talk about the project. We worked for 6 years in the Americas, first with 20 countries and then with 17 countries. One of the important things was that we were able to place the laboratories, which is a very important link in the chain, the strengthening of the laboratory, which is not present in many countries. So we have been able to show the ministers why is it important to have operating laboratories with equipment. The laboratory is very important because who will make the diagnosis, the TB diagnosis? The laboratory. Who tells you that the person has been cured? The laboratory. But if we do not have this pillar, things are not going to work well. So in the second project, in the second stage, what we were able to do is to look at the following. What is the budget of countries? What is the gap for the operational laboratories? And what is the source of the budget? Is it a national budget? Are we talking about grants? And based on the source, the functions for the laboratory to work will be sustained over time. We have had meetings with all the ministers and we have been able to explain what is going on with the laboratory and what is the sustainability level. In many countries, laboratories are dependent on their national budget and in other cases, donors. But in that case, the help will not be in the long term. So I think that this is a very important topic that thanks to the grants we have been able to carry out the study that was presented, the result of working with different countries and then explain to the ministries what is needed for the laboratory to work. And I think that this has been important and this is the way evidence is generated to be able to exert pressure. I wanted to mention that. And something that is also important in the case of TB are the information systems. We have worked in the with the 17 countries, the information system. There are a series of deficiencies. We always talk about this with Ernesto. And we have to consider that the World Health Organization works with information coming from the countries. There are many problems. We need to work with the information system to have clear data. and lay better foundations because there are many deficiencies. And if this is not improved, we will not have a clear outlook. The World Health Organization says this is like this, but when we look at the situation and we look at all the levels, the information sent to the WHO is what it uses to make decisions. The data quality. Thank you. I want to give the floor to Dr. Valentina. She is the director of the fight against tuberculosis in Peru. Good afternoon, and thanks to all. This webinar is so interesting. I want to thank for all the information that has been shared. It is very important for us as a national program to be able to implement innovations that are funded and that can be used as evidence to look the sustainability over time of interventions that could be successful. There is a lot of work that has been developed to strengthen the topic of the diagnosis. We have the World Fund that has been allocated, and based on this, we have been able to turn things around in the original project. Everything has been redirected to a diagnosis and the development of new treatment systems, and obviously the preventive therapy. There is work that is being developed right now. Sustainability that can be given to these actions is important. Precisely today, we are developing workshops by levels of government in the country where we are making the plan, the roadmap with regard to detection and treatment, how the country will give sustainability to these interventions. This is a very significant challenge. We have had the technical assistance of PAO. We have a clear guide, and I think that we should align things, align the interventions based on the government level. Carmen Navarro has mentioned this, and sustainability over time. The information system, which is basic, and we were discussing the topic of investment projects. The country returns a significant amount of the budget at the end of the year, and the regions that receive this funding do not necessarily prepare the technical files to access these funds. Also, with regard to the registration of the program's activities, not all are being registered with a single attendance form. These interaction with the different government levels, and this time we have gathered those responsible for budgets and planning of the region, help us to gather expectations and produce solutions. We have a decentralized structure. There are regional governments that manage their own budget, but there needs to be a political incidence for the sustainability of the actions from the central government. In our position as the Ministry of Health, we guarantee the supplies and medicines, what I call the backbone of the program, and the other activities are related to infrastructure, maintenance, and other necessary inputs for the patient. So this information is shared, the publications, as Dr. Lourdes said, this is important because this allows us to make decisions, and based on this evidence, approach the Ministry of Finance and say we want to do this. These are the goods and services that we need. These are the products, and this will be the impact. We are currently in that process. I think that this will be very beneficial for the country. How we will be able to reach the sustainability of these interventions in a decentralized country to control TB in the country and leave that second place that where we are now. The articulation with other programs related to HIV, these programs that we do with Dr. Benitez helps us to strengthen the preventive therapy. So I think that this information is very important and be able to socialize among everybody and assume the commitments that we have been able to put forward through the ministries. All interventions will be welcome and these publications will serve as evidence. Thank you so much. Thank you so much, Dr. Valentina. I would like to make a question with a quick answer because of time constraints. Now I want to talk about human resources. What do we need? What is that profile, human resources profile, that is necessary at the moment? We're talking about innovation, technology, opportunity. What do we need? Now, with regard to resources, in 2016, 17, 18, there has been budget allocated to recruit nurses and nursing technicians. But something important would be the diagnosis. And we have not been necessarily recruiting human resources in this connection. If I have a molecular equipment and I only give it a shift, the production of the tests will not comply with the goals we have set out. But if I assign a laboratory staff during 12 hours, according to the categorization, I will have more opportunities in the diagnosis because there are delays in the results. So I think, and I believe that this is being discussed, it is important to reorganize the human resources that we have, strengthen them in those places that need more.
No, solo adicionar que
I just
realmente
wanted to say
se debe contar con un recurso
that
humano que una capacitación continua y
there should
evitar la
be
movilidad
continuous
constante de ese
training
personal
in human
profesional.
resources
Les
and
cuento que la
avoid constant
tuberculosis se vio muy
mobility.
afectado el
The
personal de
TB
laboratorio con la pandemia de
diagnosis
COVID. Es decir,
in
mucho
terms of
personal que tuvo
personnel
que el
was
refuerzo
affected
fue
due to
necesario
COVID.
realizar para el diagnóstico de COVID en ese momento
Most
y
of that
de hecho
personnel
mucho
was
personal no
moved
regresó ya
to
a sus puestos
COVID
antiguos
diagnosis,
y es una
and a
capacitación
large number
continua
of people
y la
did not
movilidad que
return
se
to
requiere
their
y por supuesto
past
basado en toda esta
positions.
capacitación
And based
mientras
on
más
this
personal esté
treatment,
capacitado, como se decía, se va a poder tener un diagnóstico
if
mucho
we
más
have
oportuno y una eficiencia
personnel
realmente
that
en el uso
has
de las
been
nuevas
trained, we will
tecnologías.
have
Realmente
more
no debemos
efficiency in
olvidar
the use of new technologies.
capacitación
We
continua y sistemática.
should not
Las cosas
forget
cambian
this
mucho. Cada seis
systematic and
meses prácticamente
continuous
tenemos una nueva
training. Things
recomendación, tanto
change
en
a lot.
tratamiento como en
Every
el
6 months,
diagnóstico.
we
Debemos tener ese
have a new
personal.
recommendation
Por
in
supuesto,
terms of
el país
treatment
a
and
nivel central
diagnosis, and we
estar
need to have the personnel.
actualizado y después
The
poder
country at the
implantar
central
poder
level
mantener
needs to be
esa
updated
capacitación.
and,
Perfecto.
as a
Muchas gracias.
cascade, be
Adelante,
able to
doctor Leonel.
organize this training.
Sí, bueno, solo
Dr.
agregar
Leonid,
que
I
obviamente
just
nosotros ya
wanted to
sabemos que
add
partimos
that
como una
we
brecha de recursos humanos y una brecha de
are
presupuesto.
coming
Entonces,
from
ahora que tú
a
comentabas
budget
el
and
tema
human
del
resources gap.
impacto sostenible
You were mentioning the sustained impact. I just wanted to make a brief comment. Many times there is this concern. I will be judged as an authority if the incidence doesn't go down. However, we are coming from a great gap in the case of detection. We cannot be thinking about reducing the incidence in 2 or 3 years. It will probably go up, and that is bad. And we need human resources, we need to strengthen laboratories, look for the people, and we need an army, just as what happened with COVID. Look for the people, carry out an epidemiological circle. Many resources, many additional resources are needed. At the beginning, Dr. Calle mentioned the goals that were met and not met in this high-level meeting on TV. We require millions of dollars for clinical assistance, for research approaches to have the new vaccine. And the other comment that I wanted to mention in this regard was to think how the recommendations that Dr. Montoro mentioned change and will continue to change, rapidly adjust or are adapted in different countries, because we have difficult bureaucracies. If I update the technical standard or regulation, I could update it in the following years. But what happens with the changes coming up in the next few months? There needs to be solutions for this. This has to change. As we have been saying, there are more and more cases. The WHO reports tell us that there are more gaps. We can discuss about the size of the gap. They exist, and how do we protect the people with the disease? And how do we protect those people who are exposed and who will get sick if we do not protect them with the preventive therapy? If I go to a health center with 2 nurses, 50 patients, and I tell them, now you're going to be responsible for 400 people that need preventive therapy. How are they going to do this if they do not have the tools? So we need to think about innovative approaches in the case of guidance and the community and engaging approach. Carmen, I just wanted to say, as Ernesto said, this personnel is highly specialized, and probably it is a dream that there is an incentive to secure the permanence and the different guides, the different working conditions, the level of specialization needed. I think that if the personnel is not that large, we should be thinking about an incentive to retain this personnel. And something that we see in the literature with regard to human resources. We need to take advantage of community agents. The portfolio manager told us about a more community, an approach that is more focused on the community. Perhaps we could take advantage of this community approach. That was all. And now we will close. I would like to ask you for a message, a short message from Dr. Ernesto, Leonid, and Carmen. I would like you to give a final message with regard to the title of this webinar, The Cost of Inaction.
Sí. Yo lo que recalcaría realmente es el lema mundial por
I
el
would like to highlight the world message. Yes, we can end TB. It is not something impossible, even for countries with high incidence. It is not difficult to work at a sub-national level to start moving towards the elimination of TB. And above all, tackling the most vulnerable populations where there is more incidence in the region. Dr. Leonid,
Sí, bueno, primero gracias por la invitación.
first of all,
Yo lo que
thank
quiero
you for the
precisar
invitation.
la
I
inacción en tuberculosis
would like
no
to
es
say
una
that the inaction in
opción.
TB is not an
Detrás
option.
de lo que no hacemos hay mucho sufrimiento y es
There
responsable. Ese tema
is
de
much
justicia social
suffering
sería
underlying what
tratar de hacer todo lo que
we
podamos para
do
tratar
not
de
do.
disminuir
We
ese
should
sufrimiento de
try
las personas que
to do our
desafortunadamente
best to
se cruzan con
diminish the
esta
suffering
enfermedad.
of people suffering from
Yes,
this
adelante, Carmen.
disease, this terrible
Sí,
disease.
nada más
Carmen,
comentar
I
también
just wanted to
muchísimas
say
gracias y yo creo que
thank you very much.
estas presentaciones lo que nos sirve también es para ampliar,
These
¿no? Lo que
presentations
nosotros
help us
conocemos, ¿no? Sobre el
to
impacto, ¿no? O sea, independientemente de que
widen
el
our
impacto lo podamos
knowledge
medir del costo, yo creo que
about the
esa
impact,
parte, ¿no? Que es el que a veces es
regardless
difícil
of the fact that
medirlo,
we
¿no?
can
Que es ese
measure the
sufrimiento que tienen
impact.
las personas, o
It
sea,
is
esa
difficult
parte,
to
yo creo que
analyze on a
pesa
cost
más, ¿no?
basis the
Entonces
suffering
es el costo
of
de la
people.
inacción lo
I
tenemos
think that
que ver, o
the
sea, la pérdida de
cost
vida humana
of
lo hemos vivido en el COVID,
inaction has to
pero el
be
sufrimiento
tackled.
también durante el
We have
tratamiento, la
seen the loss of
familia,
lives
¿no?
with
Y es esta
COVID and
réplica
also
que se da, ¿no?
suffering,
Como
the
digo, para mí
treatment,
es
the
una guerra
family,
perniciosa,
and this
permanente, es tan
replica.
lenta que no
It
llama
is
la
a
atención, entonces
slow
tenemos que llamar la atención de alguna
disease
manera, y
that
esta es una de esas
doesn't
formas.
reveal
Muchas
itself, and we
gracias.
need
Reiteramos el
to focus our
agradecimiento por las
attention
ponentes,
on that.
ponencias del día de
We
hoy,
would like
también a
to
los videos.
thank the
Nuestro
speakers for
agradecimiento y
today, the
felicitaciones
videos,
al
and
doctor
the
Ernesto Montoro, a la
congratulations.
doctora Lucica Ditiu,
And thanks
a
for Dr.
Meredith
Ernesto
Brooks, al doctor
Motoro,
Leonid
Meredith
Leca y a la
Brooks,
doctora María del
Lucia
Carmen
Ditiu,
Navarro. A todos
Leonid
los
Leca, and Dr. Maria
participantes
Carmen
que nos
Navarro.
están
To all the
escuchando, al
participants
equipo
that
de
are
todos
listening
y a
to
todos
us,
los que están
the team
participando.
from Horas,
Cedo la
and
palabra a la
everybody here.
doctora
I would now
Marisela
like
Malqui,
to
secretaria
give the
adjunta
floor
del
to
Organismo
Marisela
Andino de
Malki,
Salud, Convenio y
Deputy
Formulario, para
Secretary
el
of
cierre de esta
Horas
importante
Cono,
actividad.
for the
Adelante, doctora.
closing of this very important
Gracias, María Elena.
activity. Thank you,
Empiezo
Maria Elena.
agradeciendo a
I
cada
would
uno de
like, first
nuestros
of all, to
excelentes
thank
ponentes, al doctor Ernesto
each of
Montoro, a la
our
doctora Lucica Ditiu,
speakers, Dr.
a la doctora
Ernesto
Meredith
Montoro,
Brooks, a la
Dr.
doctora
Lucica
María del
Ditiu,
Carmen Navarro,
Dr. Meredith
y
Brooks,
también al doctor Leonid Leca, que nos ha
Dr.
acompañado en
Leonid
este
Leca,
evento tan
who was
importante.
here today in
Y
this very
también
important
recordamos el Día de
meeting.
Tuberculosis, como decía María
Even though
Carmen al
we
comienzo, los
remember, as Maria
24
Carmen said,
24 de marzo de cada año.
every
Creo que debemos
24th
hacer
of
el
March
esfuerzo
of
suficiente
each year,
para que este
I
tema sea un
think
tema
that
permanente que
we
quede.
should make a big
Nos
effort
ha
to
mencionado, creo que todo lo que hemos visto es
ensure that
evidencia
this
dura,
is a
evidencias
permanent
con
topic.
cifras,
We have
¿no?
seen
Y
hard
lamentablemente
or
desde la
crude
primera
evidence with
reunión de alto
figures.
nivel, aquellas metas,
Unfortunately, since the first high-level meeting,
objetivos que se pusieron, pues
those
lamentablemente
goals that were set
en este segundo,
have
en
not
esta
been
segunda reunión en la que
achieved at
Ernesto
all.
nos comentaba, había
In this
gran
second
asistencia,
meeting,
600 personas,
Ernesto
600
mentioned that there
distintos
were 600
misiones,
people with
delegaciones, ministerios, ¿no?
125
Entonces, de alguna
delegations,
forma vemos que
ministers.
el tema
So we see
interesa, el
that
tema
it is an
llega a
interesting
las
topic
autoridades del más alto nivel de cada uno de
that
los
reaches
países.
the
Y
highest authorities of each country.
vemos que todavía
And
continuamos nuestros países de la
we
subregión
see
andina y lamentablemente
with
de
much
Perú,
concern
que tiene
that
las
the
altas
countries in
tasas de
the Andean
incidencia.
region, Peru,
Realmente
has the
esto
highest
requiere acciones
incidence
urgentes
rates. This
para
requires
desarrollar una
urgent
respuesta
actions to
realmente
accelerate
importante, ¿no?
an important
Ya se ha dicho en el
response.
transcurso de las presentaciones
It has been
que para
said during
disminuir
the
la incidencia,
presentations
que
that in
quisiéramos
order
todos
to
disminuir
reduce the
muertes,
incidence,
desaparecer
reduce the number
costos,
of
gastos
deaths,
catastróficos,
and
debemos
disappear
pues
these
abordar, ¿no?
catastrophic costs, we need to approach,
Multisectorial en los
we need
diferentes
to
niveles
have
de
a multi-sector
gobierno,
approach at
con
the
la
different
participación de la
government
propia
levels with the
sociedad,
participation of
utilizando toda esta
the
información, esta
society
data, estas
itself,
cifras.
using all of this information and
María Carmen
data.
Navarro nos decía
Maria Carmen Navarro was saying the Ministry of Finance, all the ministries of finance will require evidence in figures. What is the cost benefit to assign a certain budget to a sector? What will be the return? And it has been proved that it is very profitable, that this is a disease that is cured. Maria Carmen Navarro mentioned a return of $7, or $40 mentioned by other speaker. Having a comprehensive intervention will have an impact. But there is a big gap. We're not diagnosing or identifying all the cases. And the first years will need us to approach this affected population that has not been identified. And we need to understand, thanks to these spaces and other spaces, because we need to identify this gap. Otherwise, we won't be able to improve this. We have been told that this comprehensive approach, this active search with other tests, we are in this century and we shouldn't be using bacilloscopy, as Lourdes mentioned, with this big project to strengthen TB labs in 20 countries and then in 17 countries. Precisely to make it possible for countries to use molecular tests. I started in the health sector in the area of TB control in Adireza, and I have worked with new discoveries, new forms of diagnosis, new medicines. I think that we have very big expectations because we have been told that there are clinical tests for new drugs, for new vaccines. However, it is a comprehensive approach. We should not address the final part. We need prevention. Each person passes on the disease to 10 or 15 because it is airborne. We cannot afford to do nothing. And what has been quantified, as Mari Carmen said, there is a qualitative aspect, the suffering, the people that are affected in society. You cannot quantify this. There is a very important impact on their families and on the person themselves. So I think that after this event, we will be much more motivated because for Orozcono, this is one of the top priorities. It is a public health problem. We hope to solve this issue because it is something that it is a disease that can be cured, and we have this hope to control this problem. I would like to thank Lourdes for her job as a general coordinator in Orozcono, and also Valentina, whom I have known for a long time, working in the areas of prevention and control of tuberculosis. Thanks to all the attendees, thanks to the team at Orozcono, who help us to have these important events on a weekly basis. And we would like to invite you next week at 11 a.m. We would have a webinar with the British Embassy. It's called British Vision of Health Experience and Progress. It is very important since we are talking about innovation, technology, the importance of artificial intelligence. Thank you so much and see you soon. Thank you, Marianela.
Gracias.